Previously, for an aortic valve repair, it would be a large open heart sternotomy procedure, and they would replace it with either like an xenotransplant, so like a bovine valve, or they would replace it with a mechanical valve. Recently, they've been doing it percutaneously through the groin. It's called a TAVI, transaortic valve implantation. So people aren't going to ICU afterwards. They're going down to CCU, spending a couple of days being externally paced there, and then they go home. It's quite cool. Does anyone know the difference between having like a live tissue valve implementation and a mechanical valve implementation? So the mechanical valve makes that clicking noise, and they need to be anticoagulated for life because it's a large clot risk. And the longevity of each of them are different as well. So we have a case study. So a 75-year-old man with a past medical history of rheumatic heart disease, a STEMI with PCI in 2012, previous ETOH abuse, GORD, anxiety, past surgical history of a triple cabbage in 2013 and an MVR in 1980. So this admission, he's come into DEM with some chest pain, some shortness of breath on exertion, and just general malaise. They've done troponins, BNPs, coags, Chem20, chest radiography. A TTE has showed he's got a new left ventricular ejection fraction of 20%. He comes to the ward. You're coming on to a late shift. He's got a sudden increase in shortness of breath, an increased work of breathing. His SpO2 is sitting at about 89 to 92% on room air. He's got bibasal coarse crackles and a displaced apical heartbeat. What is this man's what could his possible diagnosis be? This acute problem, what's his primary issue right at this point? Maybe some
fluid overload.
Yeah, some acute pulmonary edema. Yeah, so what's the pathophysiology occurring with this left ventricular ejection fraction being so low? So do you know what's happening in the left ventricle that's making
It's regurgitating back.
Yeah, so there's a whole heap of congestion. Yeah. So suggestions on management. So how would you handle APO?
So needs diuretics.
Yep.
Yeah.
Oh.
So the new diagnosis is left-sided heart failure, and he's in acute pulmonary edema. So his pathophysiology is blood is unable to be pumped from the left side of the heart efficiently. This causes congestion of the respiratory system and raises the intravascular pressure, causing fluid to leak in the surrounding interstitial lung tissues. This causes a pulmonary edema to take place, so this is quite serious. Suggestions for care: he would be murdered, obviously. He needs diuretics. Non-invasive ventilation is like the number one, like after diuretics treatment for APO, because we don't want to use BiPAP, we use CPAP, the continuous positive airway pressure, because that continuous positive air forces open the alveoli to like enforce the gas exchange. He'd need continuous cardiac monitoring, IDC, FBC, strict fluid balance, and query and outline for systolic blood pressure monitoring, because if we're taking all that fluid off him so quickly, we would be worried about him dropping down. I just wanted to touch quickly on ejection fractions, because Mel Bonnick asked me about them, and I don't actually know an awful lot. So a preserved ejection fraction, also referred to as diastolic heart failure. The heart muscle contracts normally, but the ventricles do not relax, as they should be during ventricular filling. Then a reduced ejection fraction, also referred to as a systolic heart failure. The heart muscle does not contract effectively unless oxygen-rich blood is pumped out or to the body. So some numbers to do with ejection fraction. So a below 40 displays some heart failure. 41 to 49 suggests some element of heart failure, and an ejection above 75% is too high. So there's too much pressure from that left ventricle. So they think hypertrophic cardiomyopathy. So the heart's so big, it's pumping out so forcefully, it's causing some damage. Right heart failure, so left heart failure, we see respiratory congestion. Left heart failure, and then right heart failure, you'll see peripheral congestion. So you'll see people with peripheral, like pitting peripheral edemas. So just touching very, very briefly on ECGs. So ECG, does everyone, what's an ECG?
Cardiology.
Yeah. So what displays on the ECG can be described as a rhythm, and this is made up of a P wave, a QRS interval, and a T wave. Can anyone interpret these? They're only easy ones, I promise. So, without cheating.
Atrial flutter.
Yeah, you're a cheater. You're a paramedic.
Atrial flutter.
So we'll go into what they look like on the. So.
Sinus rhythm.
Sinus rhythm. So everyone can see a P wave, a QRS interval, and a T wave. Yeah. So this is a bit of a scary one.
BF.
Yeah, ventricular fibrillation. Yeah, which is a
Cardiac arrest.
shockable rhythm, yeah. What about this one?
VT.
Yeah.
Yeah. So what's different about VT to VF even though it's a shockable rhythm?
So VF usually comes before VT and the heart's like quivering. No, VT comes before VF.
Yeah.
Yeah.
So you can be conscious with VT.
Yeah.
It's very unlikely in VF. Actually, you won't be conscious at all. And yes, so there's VT and then there's supraventricular tachycardia, which you can also be conscious with, but we won't do that today. So this is a bit of a trick one. Can anyone identify what's going on here?
Looks like a normal size with a PVC.
Hey!
Sorry.
What's the most common cause for PVCs we see here on an ECG? It's medication induced. Salbutamol. And this one's the most common one of all. Every second man and woman has this on our ward right now. AF. And how would we identify AF?
Lack of a P wave.
Yeah, lack of a P wave and those irregular QRS intervals. So you can see that the spacing between them is irregular. All right, well done, team. So just briefly going over what a P wave is. So the P wave is the atria depolarizing. The right atrium depolarizes slightly earlier than the left atrium as the SA node is found at the top of the right atrium. QRS complex is the depolarizing of the right and left ventricles, and a T wave. The ventricles repolarizing. The time between the QRS and the apex of the T wave is considered a refractory period, so when the heart's kind of just getting ready to go boom again. So let's look at some basic common rhythms, which we've just done. So atrial fibrillation is an atrial quiver due to electrical disturbances. The atria are unable to empty correctly, commonly presents with palpitations, very high risk of stroke and clots, and lack of a P wave with an irregular beat. Can anyone tell me why AF, they need to be warfarinized or anticoagulated?
Risk of stroke.
Yeah.
Yeah, so what's the cause of the risk of stroke?
It sort of builds up into.
Yeah, so pooling of blood, yeah, in the right atrium. So they think that there's like 30% blood left over in every refractory period. Atrial flutter. So there's a circular electrical circuit making the atria contract faster than the ventricles. Presents with a regular beat and a sawtooth pattern. So when we looked at that, a little shaky. So with atrial fibrillation, there won't be a P wave, and quite often the QRS complex will be close together, long. With atrial flutter, the QRS will be regular. Ventricular tachycardia, ventricles contracting too quickly for sufficient filling and emptying to occur. Ventricular fibrillation, are non-sustainable with life. Electrical impulses of the heart fire too quickly, rendering the ventricles unable to contract. The ventricle instead quiver, therefore blood not being pumped around the body, which means no life.
Not long now.
No. Premature ventricular contractions is just an extraventricular contraction, common causes of palpitations. And that flutter that people get in their chest. And obviously I didn't put up asystole because that's too easy. And asystole is non-compatible with life and it's no electrical impulse whatsoever.
Do you have any of the ones for an MI?
Yes,
They're
I do
usually
have a
like
STEMI.
deep,
Yeah, there's just a very brief touch on that. So asystole is obviously not shockable. It's only reliable with CPR and drugs, but even they're querying whether adrenaline and atropine are actually that effective during an asystole arrest. So a STEMI versus a non-STEMI. So an ST elevated MI usually occurs with a full occlusion of one of the coronary arteries, and a non-ST elevated MI commonly occurs when there is a partial occlusion of the coronary artery. So how is a non-ST MI diagnosed without being able to view on an ECG? There are quite often ECG changes with non-STEMIs, it's just not ST elevation. It usually involves the T wave or whereabouts the MI occurs. So how would we diagnose it? So they'd have troponins and they'd have a positive BNP. So it's usually bloods associated with like a typical chest pain, that kind of thing. They can also go in for an angiogram if they think they've had a non-STEMI and do some investigation. So you won't actually become symptomatic with chest pain caused by atherosclerosis until you've got an occlusion up to 70% in one of your coronary arteries. So you can present with a non-STEMI with quite a significant amount of build-up in one of your coronary arteries.
Oh,
You're done.
thank you.
That was nice. I'm getting back to feeling very down.
Oh, and there's just, we'll pass this around, I just did print out the difference between an ST elevation and just a normal sinus.
How do you know when she
She loves it. It's her